So hello everyone and welcome to today's Reverse Rett Bitesize session on reflux. These sessions have been brought to you through a new Reverse Rett project called Rett Connect, which is funded by the Pears Foundation. Throughout May, we've been running bite-sized sessions on lots of different topics, and they've been also parent expert panels, which has been very interesting. And so far, we've had sessions on scoliosis, surgery, and gastrostomies. And today's is the last one of this format this month. And we are welcoming Helen, Motility, Debbie, and Christine. Is Debbie here?
I don't think we saw her arrive.
Okay, so it may just be Helen, Motility, and Christine. So I should say the discussion today is going to be focused on the personal experience of the people involved. And so obviously it isn't intended as medical advice. If you do have any questions, I thought this was coffee. It's air freshener, right? And probably not a good time then.
No, it's actually.
Okay, sorry. Right, if this video was clipped, I should just put in some real life here, which is dog poo has been walked in my office, and so it's now being cleaned up. Right, back to reflux. If you have any questions throughout the session, please feel free to raise your hand or just to write in and ask the questions. I'm sure that would be fine. And if you keep yourself on mute until you have a question, that helps with the sound. Also for the speakers, if you keep yourself on mute till you're speaking, that's perfect. We understand that there's a slight delay. And we will be recording the session today. So as always, if you don't want to be on camera or if you have something happen and you need to go off, that's fine. So really appreciate you guys giving the time to us today, and Helen and Motility, you've both given time to us on other sessions as well, and we appreciate it. Lots of people do listen to these after the fact, so I will ask each of you to introduce yourselves briefly. Where you live, tell us your daughter's name and the age she was when you first started to realize that she had reflux. And the best thing is if we don't have your whole story up front, so just give us that little bit of a snippet, then we'll move to the next person, and then we'll come back to the next sort of stage of illness and do everybody at the same time, if that makes sense. So I'm going to start with Motility and then move to Helen and Christine. So Motility, over to you.
Thank you. So we live in North London, in the London Borough of Enfield. I have just one daughter at the moment. She is 10 years old. I think reflux is a hard one to detect, purely because there's no external symptoms necessarily unless it's severe reflux. So I think we started noticing Tara complaining a lot from the age of 4, 5, that kind of age. And so I think she must have been having heartburn. And then in the later years, she did start having vomiting. So that's why we think that was a sign of reflux. Yeah, I think that's that, isn't it?
Yeah, that's super. So Helen, what about yourself?
I'm Helen Simmons. My daughter is Lauren. She's 14. We live in Wokingham in Berkshire. Again, like Motility said, it's a difficult one to kind of pinpoint the exact time we started noticing things. And I'm not sure that we actually did. We were putting it down to other things. So I think it was present from an early age. But again, around about 4 or 5 is when we started seeing kind of significant reactions to what was potentially reflux.
Christine?
Hi, thank you. My name is Christine Flint. I live in Gateshead, the northeast, and my daughter is Neve, and she's 13. And similar to the other two ladies, we think that Neve was probably about 3 or 4 when we started to notice that something wasn't quite right. And again, we didn't identify immediately that it was reflux. We weren't sure what it was. What we noticed is that she was a little bit sickly at times, a little bit pale. Neve did vomit. We actually put it down to travel sickness, because when we used to travel distances, well, I'm saying distances, even only a few miles, she used to be worse after car journey. So for quite a few months, we actually thought it was travel sickness. And then it wasn't until kind of later on, after a few investigations, that we realised it wasn't. So that's our kind of little mini story.
Okay, thank you. That's interesting to hear. But so when you first started to see that she was having these problems, how did you deal with it then? You thought it was the car journeys, and then
yeah, so I think I can't try to think kind of how we did deal with it then. I think I started keeping a diary, which is something that I learned on quite early. With Neve's presentation, there's lots of things that we really struggled with, and we found diaries were really quite good at trying to kind of figure out what the pattern was. But she was vomiting, and I think we just went to the doctors, and they just said, look, we could try some medication to settle her stomach, just to see if that helps. And so we actually got prescribed lansoprazole, and it literally worked overnight. It was something that worked. So that was the point, I think, where we knew what it was.
that's very good. Motility, was the same sort of thing for you?
Sorry, did you say something, Rachel? I didn't hear you there.
I don't understand why my sound is a bit off. Was it the same sort of thing for you, Minity?
Okay, so what we had a pH test done where they put this tube down the nasal thing all the way down the throat, and which was a very unpleasant experience, because she ended up bleeding and stuff. But anyway, we got it down there, and they said, yeah, Tara does have a bit of acid, not a significant one, but yeah, some acid. And this is the bit I don't like, and I'll probably mention this later on in the call, where consultants are very quick to say, oh, okay, we're just going to put her on some medication. And it was like omeprazole that was first prescribed. And the consultant's view was, oh, a lot of Rett children have reflux, so we might as well put Tara on the medication. And looking at the long list of side effects of the medication, I was like, oh my gosh, do I give this? And the consultant was like, well, give it, and if there's any adverse effects, you'll notice it. Okay, so we went ahead with it, and we didn't notice it didn't help with the problem. It really did not help us. And we were quite keen to get a bit more further investigations done, like you hear about endoscopy, which have like fancy cameras in them, which can investigate. And the consultant's view was that, nah, that's not necessary, just carry on with the medicine. And we even switched to, I can't remember the exact timelines, but we did eventually switch to lansoprazole, which seemed to help for just about 3 months, and then stopped helping for us. So yeah, we went on to different avenues from our own thing, but I felt like, oh yeah, by the way, Tara had a lot more vomiting at this stage. She was also she had the peg put into her stomach because she wasn't feeding very well, and she was on the formula milk for a good couple of years. And I think that contributed to the reflux as well. There'll be moments where she's sitting there and all of a sudden, it's just, they called it projectile vomiting. And that was definitely a sign that it was reflux. But on the other hand, we've got these medications which weren't really helping. And I wasn't, to be honest, too happy giving a medication which has this long list of side effects and wasn't helping.
Yeah. So it's interesting to hear that some people seem to have the pH probe first, and some people the doctors will say, okay, we'll just try it. This has always been something, try medication. That's something that's always been confusing to me, because puts a lot of parents off addressing this symptom because they don't want to have the pH probe. Quite rightly, it's horrible. Helen, did you have the pH probe, or did you just go on to try medication and see?
No, she didn't have it because the consultant we had at the time said it was too invasive. He didn't like doing it unless symptoms were less obvious, and he thought it might be what they class as silent reflux, but he thought hers was more classic presentation. At the time, she was still feeding orally, and she didn't have her gastrostomy until she was 9 or 10. So she was still feeding orally, and we were really struggling with that. So it was evident to us that certain foods would cause a reaction a bit quicker. And we had to be really careful with how we dealt with her timings during the day. So it would be a case of feeding her, and again, like Christine said, keeping a diary so that we could work out the best way to sort of manage her. So making sure that she didn't eat anything sort of beyond 6 o'clock, eat or drink anything. Otherwise, we'd really struggle when she went to bed. Making sure that if she had food or drink, that she then didn't lay down for a good hour or so afterwards. So it really kind of impacted on her day, and also on her school day, especially. It was a bit tricky. So we went the medication route first, and actually the medication they put us on initially was just Gaviscon that you could buy over the counter, and ranitidine, which now isn't licensed, I don't think, so you can't get hold of that anymore. But she was on that concoction for quite a number of years, actually, before we changed to anything else. She then got put onto omeprazole, and then most recently, and is still on, lansoprazole. So we've kind of gone through quite a mixture, but yeah, thankfully we didn't have to go that pH route, because I think it is nasty for them to have done. It's not something to take lightly.
Yeah.
But the only other test that they did actually that was really a really good visual way for us to see how it was reacting, the reflux was reacting, was that she was put on what they call a tilt table. So basically a flatbed table, and it literally tilts upwards. So their head goes down towards the floor. So she was given a barium swallow, a barium drink, and then put on the tilt table and tilted back, so we could see a kind of live X-ray and video of how things were affecting in her stomach. And that was really good because it was conclusive. We could see immediately how things they hit her stomach, and within seconds they were coming back up her esophagus and into her mouth. And it was at that point that he suggested that we need to try looking towards a gastrostomy, because at that point she was also on quite a lot of other medication for other symptoms, and we were really struggling with getting her medication in anyway orally, without her spitting them out. But the ranitidine that was actually given for the reflux was so vile to taste and so strong that actually giving that orally was such a fight. It was one of the worst ones, yet that was what was prescribed to try and help her. So at that point we knew the gastrostomy was the only route that we could take, really, for making sure that the medication was going in and helping the helping the reflux itself.
Well, I suppose one of the problems is if you're somebody that's experiencing this all the time, where you've got sort of acid coming back into your mouth, it puts you off eating, drinking, and basically anything anyone's trying to get down you.
Yeah.
I'm going to go back to that, but first I'd like to welcome in Debbie and Louise, who've just joined. And Debbie, we've got to a point where we've kind of introduced Minity, Christine and Helen and their children, who are not children anymore. Neve's 13, Lauren is 13, 14, and Tara is 10. Yay. So how old is Shona? Tell us a little bit about Shona, where she's up to, when you knew she had reflux. Don't give us the whole story, because we'll go to you know, just the beginning of it and how you first addressed it, and then we'll move on.
Yeah, Shona's 14, so Shona will be 15 this year, and just it's just like, you know, you go through one thing and then it's the next thing. It's like, so we kind of got through the epilepsy, and then all of a sudden just started to realize that she was really struggling with her secretions more than anything. I thought, you know, what's going on here? Vomit and bile. We've had the peg tube put in a long time ago. I think that was one of the best things we ever did, to get medicines into her and everything like that. But she wasn't, and I think she should have been covered with an omeprazole or something at that time. When we were given epilepsy drugs, we were given you know, baclofen and things for tone and whatever else. They never offered any cover for her stomach wise, so I don't think that was helpful. So I would imagine now anybody that's kind of putting drugs into their child should be asking for a cover to maybe prevent some of these things. I don't know. They say, well, obviously Rett syndrome, oh, these come part and parcel. It doesn't matter what you do, these problems you'll get. But I think definitely if your child's taking drugs, definitely need to have cover for their stomach. So you could tell that she was struggling, and she was vomiting, and by obviously with the peg tube, you can, when you aspirate it, we could see that it was like blood flecked black bile, and that was what she was throwing up as well. You know, didn't like to be lying on her back, really struggled to, looking at you in a very panicked way, as if like she was drowning, you know, like she just couldn't cope with it at all. And that's in a bed, you know, that a hospital bed, but where she's elevated and properly positioned, she still couldn't cope with being lying down. So
what age was this? Sorry.
This has just been over the last 2 years, really, that it's got so bad. Yeah, I mean, I think she's always had some form of reflux, but really this is like its pinnacle point, that it's just got such a big problem. So now at the moment omeprazole. Omeprazole's terrible for blocking the peg tube, terrible, but lansoprazole, we're now on 30 milligrams of lansoprazole. She's had a pH study, she's had a scope down to have a look, said that her esophagus is really, really badly sort of scarred almost with this reflux, and it's just they don't really have any particular options really. That we've tried domperidone. She had a really bad reaction to domperidone. It's not a drug that they like to use with children, not a drug thing they like to use with anybody, I think. So we had to go and have like her like QT checked, so they would be monitoring like her heart and everything, because domperidone, the problem with that is that it tends to cause heart problems. So we went through all the initial checks and guaranteed that she would be 6 monthly checked if she was going to be on this drug, but then she reacted with it, so we actually, after day 4 of the drug, couldn't use it. So they're going to try another drug, which I can't remember the name of, but it's another type of drug, I think, to help motility, so we're going to give that a go. But yeah,
listen, right, because I need to just stop you for a second, because some people might be watching this who are at the beginning, okay?
Yeah.
And when certain words that you're using, we're all going, yeah, but we need to
yeah,
for a second. So when you're talking about motility, that's about the speed at which the food and so on is going through her digestive system, is that right?
Yeah, that's it. Just basically that it's I think the point is it tries to control the acid somehow by doing that, by filtering the stomach through quicker it's supposed to deal with the acid. That's how I've, in layman's terms, kind of got to grips with what they were saying. But
So
to
let's
be
just
honest,
go. I just need to scroll back a little bit as well, okay?
Mhm.
Because compared to the others, yours has come on later. And one of the things that you said was, you know, obviously our children with Rett syndrome end up on quite a few medications. And I was
Yeah.
very in the beginning, you know, I don't want my daughter on loads of medication. I think the
Yeah,
first
me
thing she
too,
was on
yeah.
was epilepsy meds. And now she's got, I think, 16 different things
Yeah,
going into her
they
mind.
build up, don't they?
Sometimes it's about the lesser of two evils, but you also have to be aware in Rett syndrome that any medication that you're on, as you've said about the domperidone, like might affect other things, and so it's always
Yeah.
being
Well, this is
mindful
the
of that.
complication. We're having lots of different drugs as well. They interact with each other, so you really need to be careful. And you can't always think that the doctors will actually have like looked at that. Sometimes you have to really be the person that's going right, asking the right questions. You know, you realize she is on X, Y, and Z drugs. Will this affect? Because, you know, quite often they don't seem to. Oh, they go, oh, you're like, you had one job.
Well, do you think that it's a question of they deal with their own body part and then they're not really looking at the
Yeah, absolutely. Yeah,
parts?
there's one done to their own part, aren't they?
Yeah, that's a really important point. So, but you did say that you felt like the drugs that she'd already been on had made her stomach sensitive. So at what point do you think, you know, so for example, I know ibuprofen gives you loads of other problems because
Yeah.
I suffered a long time with migraines. And so I was always whacking down, even just as a preventative. I don't want to have a headache today, whack down a couple of ibuprofen. And over time, they can cause you a stomach problem, which I've now
Yeah.
got, and some other things. So what, do you know what drugs were causing Shona problems with her
But
stomach?
no, you're on epilum trihexyphenidyl. Most of the drugs are just for epilepsy and tone, really. But I would say now that if your child is going to be on more than one drug, I would be asking the doctor straight up. You know, obviously these drugs, whether they're going in orally or they're going in through the peg, they're going into the stomach. And I would say, what do you think about stomach cover? Do you think over time, if they're going to be long-term drugs that the children are going to be on, or young adults are going to be on, saying, you know, what do you think about stomach cover? Do you think it would be sensible to put them on omeprazole or some sort of thing to prevent? You can only try and prevent, you know. And I don't think that was ever offered, and I don't know if she would have just had the problems anyway. But I think it would have been sensible to have had her on something.
Yeah.
So I would say if you're child.
The other thing that I was going to say was, I know when you were talking about Shona having blood flecked bile and you know, reflux and the black bile in the peg, presumably coming out
Yeah.
through the
And vomiting it.
and Christine was nodding when you said that, but I just wanted to say it. To me, Amber's got quite bad reflux too, but I'm probably not as bad as you guys, all four of you. That's not normal though, is it? Sometimes you don't have that. Sometimes you don't have the blood. Sometimes it's just the person kind of looking very uncomfortable. This, like as Debbie was describing, looking kind of startled. There's another sign. So can we just call out what the signs are for people?
Just like every time that I go to get Shona up from her bed in the morning, she has like a halo of wet around her. So I think Shona's still got a bit of a swallow, but she's managing this all the time, what's coming up, storing it, spitting it out, storing it, spitting it out. So she becomes very like saturated almost, putting like a pad or putting something behind her to help her. It must be a terrible thing to deal with, especially when you can't speak and you can't say, right, I need to get up. It's just that wee panic look.
Yeah. So I think the other thing is
quite. No, I was going to say I think it could be quite a silent thing for a lot of children if you weren't aware of it, because children with special needs in general they have a lot of saliva, they can drool a lot, you know, for various different reasons, and so I think it can be overlooked. if they are
Yeah.
struggling with something.
But and that's
especially
an
like
important point. But I want to get the thing that I want to emphasize now for people watching and listening is, why does it matter? So, for example, for many years I thought for reflux, well, yeah, it's a bit uncomfortable. It's something people take some Tums for. You know, I had it when I was pregnant. It's a nuisance. The end. Okay.
yeah.
But it's more serious than that in Rett syndrome. So can one of you, I don't mind who, probably actually Christine, I'm going to pick on you if you don't mind. Can you explain why, you know, that it's not a safe thing to have just happening in people with Rett syndrome?
Well, I think generally, I think what we found with, I can only speak for Neve, of course, but we felt as though it had a massive impact on our quality of life. So I think, you know, pain is a symptom. I think probably the biggest thing for us was the vomiting. That was a real risk factor. And that's kind of what drove us to look at solutions and, you know, really explore the options, because we got to the point when Neve was vomiting quite frequently, and then she began aspirating, and she kind of fell into a pattern, so that every time she was poorly with a chest infection or pneumonia, that would be accompanied by vomiting, and it was all exacerbated by the reflux. There's absolutely no doubt about it. So by this point, Neve had already had a feeding tube. Neve had a feeding tube put in when she was probably about 3 or 4. It was right about the same time. And then they said, okay, we probably need to look at doing a fund duplication. And the reason for why they did the fund duplication, and the fund duplication is basically just tying the top of the stomach. And the idea behind it is to stop the kind of the reflux and the acid splashing back up the throat. And the reason why we were advised to get a fund duplication was because of the risk of aspiration and the risk of vomiting. So every time Neve was poorly, which was quite frequent, she would vomit. So that was kind of the route that we kind of got forced to go down, really. We didn't really feel we had any other options. The paediatricians kind of felt it was too unsafe not to do, so we went down that route. And when they were doing that surgery, they found that she had a hiatus hernia, and they found that she had lots of damage caused by the reflux, and we had no idea. It wasn't until they obviously had went in and done the surgery. So we had the fund duplication done. That caused issues. Rachel, I don't know if you want me to go on from there and kind of go on to the rest of our story.
No. What I'll do is we'll go to, just because the thing is, I need to better understand certain elements of it, then we'll move on to if that was actually helpful. I think one thing I just want to quickly go back to is this difficulty with the initial pH probe. So I think, Minity, you mentioned that Tara had a pH probe, but also an endoscopy. And I found that endoscopy was easier than having the pH probe. So can you speak to that?
She didn't have the camera put in. No, she had the pH thing. But I just wanted to kind of backtrack on what Christine said. It definitely does impact the quality of life. And obviously stuff like vomiting is serious. And not to mention the inconvenience, like, you know, you've got, if we were to feel vomit coming on, we would go to a basin or toilet and puke it out. But we've got children here who can't say that, Mum, I'm about to puke out, and it just comes out, and you're left with a ton of washing up to do, which is really overwhelming. And for Tara, I felt like it was, I think the way we know it's kind of maybe reflux is when you try to lie them down in bed or when they're trying to sleep, it's really discomforting. And with Tara, when she did have the the peg put in, we were able to vent her out. So we know it's not trapped wind. And it's when we will lift her upwards. We don't have a profile bed, by the way. So we lift her up and we could see this instant kind of slight relief coming on, like, I'm happy to be upwards, you know, not lying down. And yeah, she'll still be in discomfort, and we would try and distract her with other means. But I definitely think it does, it hinders sleep. And if children are not sleeping, parents or carers can't sleep, and you're like pretty much awake the whole night. So I think definitely can't be underestimated. Yeah, it's not probably a life-threatening to that extent, but definitely tiring, exhausting?
Well, I mean, the thing is, obviously, you know, pain is not to be underestimated, and that discomfort that people have. And also for some people, they need to be able to eat to maintain their weight. And if they're not able to eat, you know, that can affect their health. But I suppose the thing I was really trying to get at was this issue about aspiration. So people can aspirate on their reflux, they can aspirate on their secretion. So a lot of the time, I think in Rett syndrome or other disabilities, even people might think are a bit, you know, having a bit of just having a bit of secretions or being a bit drooly, just to explain what that is not really a big deal. It's cosmetic. It isn't cosmetic because you can inhale any of that sort of liquid and then develop chest infections on top of it. And in Rett syndrome, people often can inhale food, drink, or their own saliva without making a noise, and then it just causing them, you know, themselves to have chest infections, which can be lethal. So it is important that it gets addressed, even if it doesn't get properly explored. Even if you just try medication, it's better than not doing anything. Now, that isn't medical advice, but that is what we are gleaning from the health checklist, the Rett Disorders Health Checklist, and from our work with the SIP Rett Centre as well. So we are, who here has had a fundoplication then, and who has not? Is it just you? So Helen and Christine. So Helen.
Sorry, no, they said that with the fundoplication was showing us that could actually turn the stomach more into like a pressure cooker by holding it all in with all the acid. That they said that actually for some children it works and for some children it doesn't. It's not advised.
How do they make that distinction then?
I have no idea.
Okay.
It must just be from what you're telling them. They never did a particular test to discover that. They just said, well, don't think in Shona's case this would be a good idea. But yeah, obviously they do it in other people. So I don't know.
Helen, maybe you can give us some insight into why that decision was made for Lauren, then, so that we can try and work that one out.
So for her, it was a little bit different because after she had the gastrostomy in 2017, at the beginning of 2017, the reflux issue, even though we could get her medication in much more reliably, she was still eating orally, but we could obviously top up with the milk feeds and things like that. So that's what we were doing to try and combat her weight issue, because she has always historically struggled with gaining and maintaining weight. So we were dealing with a combination of the sort of gastro consultant and dietitian in order to try and combat that and cover the reflux. But in conjunction with all of that, her scoliosis was getting significantly worse. And in doing so, was making the reflux worse, because the curve in her spine was putting pressure on her stomach, which was causing more reflux. So we were then told she needed to have spinal surgery. But the reflux had got so bad that actually it was triggering epileptic seizures. So every night she would have what we thought were seizures. They presented very much like seizures. But a very distinct thing that she would do is, as she would do it sitting in a chair as well as when she was in bed, but her head and her neck would turn very dramatically to the left, and she would kind of elevate her head up. And when we talked to the gastro consultant about that, he said that there's a condition called Sanderford's syndrome, which he clinically diagnosed Lauren as having, because basically what she was doing in doing this motion with her neck during what looked like an epileptic seizure, she was actually blocking her esophagus. It was quite clever, but she had worked out that by doing that, it kind of closed up that hole, so not so much could come back up. But it would be very dramatic, and actually these episodes would carry on, and they were lasting sort of 15 minutes or so. And then they would turn into epileptic seizures. So it was really difficult to distinguish between the two, really. But she had EEGs done, and it highlighted that they were epileptic as well. So the reflux essentially was triggering epilepsy, or making it significantly worse. And given the news that we were now on the waiting list for spinal surgery, the last thing that we wanted was for her to go in under this 9-hour operation on her back, then come out laying on her back, and then have a massive seizure, putting everything at risk of the work that had just been done. So we really needed to get on top of that, and her spinal surgery was quite urgent at that point. And obviously the pressure it was putting on all of her organs internally, including her stomach, was really significant. So that's why the decision was made that she should have the fundoplication prior to having the spinal surgery, so that we could try our best to get on top of it. And it was kind of sold to us as though it was, I remember us just being given a leaflet, a black and white printed piece of paper. He very quickly explained they kind of wrap the top of the stomach around itself and pin in place. And as Christine said, it just stops everything coming back up. There's still a hole in order for stuff to go down. So if you eat orally or drink, you can still do that, but you just have to be mindful that smaller amounts need to go in. And certainly to begin with, it needs to be very soft stuff going through a smaller hole, but it just stops so much coming back up. So she had that fundoplication surgery, but actually it was a much bigger operation than we anticipated, and the recovery was much bigger. And kind of delayed the spinal surgery a little bit. So I don't think it's something that should be taken lightly. It certainly do some investigation if you ever get to the point where fundoplication is mentioned, and just ask lots of questions about it, because I think as well for our children that don't have those communication skills, it's very difficult for them when they first have it done, to be, especially if they are still eating orally, to be able to manage that whole flow. It certainly helped with the reflux, not 100%, and we have had moments since then when the reflux has presented itself really significantly back again, and she's had to have another tilt test to see actually whether the fundoplication has loosened, because that can happen over time.
Do you still take medicine for reflux after you've had fundoplication then? Yeah.
She has. So she's now on lansoprazole, just to help with that, to make sure. To be honest, I think it's more to do with her being able to gain weight as well. And like Christine said, it wasn't until they went in to do the gastrostomy actually that they could see the state of her esophagus and see the scarring that was there. And it wasn't too bad at that point. But I think had we not had that fundoplication done, by now it would have been. So I don't regret having it done, but it was a much bigger event than we were told it would be.
And Christine, you've been nodding when Helen said, this is a bigger surgery than we imagined. Because to be honest with you, I've kind of made that assumption as well, is that it's not a big surgery, because the gastrostomy surgery is very quick most of the time. So what is it, what is it that makes it a bigger surgery in terms of the operation itself and the recovery?
So I think it was post surgery and the impact of the fundoplication on Neve. We really didn't anticipate what happened. So just kind of, I was quite interested to hear that Helen's daughter's still on medication. We managed to stop the medication. We did have some anxieties about stopping the medication because the lansoprazole to us was like a lifeline. It made a massive difference, but we thought we'll just trial it. So we tried her off the medication, and actually she was fine. And we've never had to reintroduce it, but you know, different kids are different, aren't they, and different children. So, you know, Neve responded okay. The biggest thing for us after the operation was that almost immediately after the next day, when we tried to introduce the feeding again. So Neve was on a peg fed and she was formula fed at this point, and she began retching. So every time we began to feed her, she began retching, and this was new, and we didn't anticipate this. We spoke to the surgeon, and the surgeon then said, yeah, actually it can be quite common. Now I can't remember the term that he used. There is a term, Helen, you might know it, I don't know, but it's a term that, you know, children can experience post fundoplication. And we basically got told, that's it, you know, you're gonna have to just learn to live with that. But what it meant was that Neve couldn't even tolerate like the tiniest amounts of formula. I'm talking literally 10 mils. You know, we would try to give her 10 mils and she would retch. And it wasn't just the retching, it was the retching caused secretions. The secretions then caused a lot of discomfort, and then aspiration. So it was a massive knock-on effect. And for 3 months, probably not actually 3 months, probably just a few weeks, it was incredibly stressful. So the problem that we had is we couldn't get the food into Neve. So every time we tried to feed her formula, she was just retching. Before the fundoplication, she was absolutely tolerating formula. No, there was no issues, there was no problem. But it was following the fundoplication we had major issues. So she lost weight because she couldn't tolerate the feed. So we must have took her into hospital, into A&E several times, and they basically just couldn't do anything. You know, they just said, you know, basically get used to it. They ended up prescribing alamimazine, which is a medication that's used for motion sickness, but it's also like a sedative. And we tried that, and it just basically sedated her. And I just said, look, we cannot, you know, I cannot give this to my child. It's no life. This is horrific. And it was a really kind of defining moment, I think, for us as parents, because we kind of felt like we were lost, and we felt like we had absolutely no support. She'd had this major surgery, and we were kind of left in the situation where she suddenly overnight couldn't tolerate her feeds. So basically I kind of went on the internet and just did loads and loads of research into post fundoplication problems, and there was quite a bit of research in America that I came across, and that's where the story of blended diet in terms of feed, that's where it came in. But I'll not go too far ahead, Rachel, because you probably want to explore the options before I kind of go down that avenue.
Well, funnily enough, I was thinking that would be the next thing that came up, because I know. Let's put it this way. So there's 2 of you here that have had the fundoplication, and there's 2 that haven't had the fundoplication. So maybe we go to you, Minity, and you can tell us what has worked for you. So did the drugs work straight away, or did you find that you had to do other things and subsequently blended diet?
Yeah, so one thing I regret about consultants in this country not doing is taking a holistic approach. And one of you mentioned how they just focus on their little area and their little list of medicines that they have in their thing. And we'll get this out, we'll try this out. And they just don't explore other avenues. And I think that puts a lot of onus on the parents to kind of look for solutions themselves. So the few things that have worked for us is Gaviscon. I must say, in terms of medication, Gaviscon has been a lifesaver. And Ranitidine, it tastes horrible, I know. Even that worked pretty well for Tara, but then, as you know, that one got discontinued, and there wasn't really an alternative for that. So for a number of years, we've been giving Tara digestive enzymes. So these like capsules you just open up, and it's supposed to help with the processing of food. I did ask for there's a medication called domperidone, which is supposed to help food go quickly, but the consultant wasn't too keen on giving that, so hence why we looked at other avenues. So we also have a lot, herbs. In my culture, we have a lot of herbs and spices, so we looked at ones which would help Tara. Yes, they do help, but they're not as effective, quick, not fast reacting, so you've got to be very patient with those kind of things. But the biggest help that happened for Tara is when we did move from formula to blended diet. And one of the instant things we noticed was she stopped doing the projectile vomiting. That was a big relief. And it was a big battle as well, trying to get that introduced in school. At home, we were free to do what we wanted, but at school, it took over a year for it to be accepted by the dietitian and by the school. Well, even then, it only got accepted when there was a change of dietitian and change of teacher. But yeah, so we did do the blended diet, and definitely helped. I mean, we still have to keep an eye on her calories and stuff. I think the dietitian is concerned that Tara doesn't get, that we don't missing out on the calories. So we are on top of that as well. But in the last few months, we noticed that Tara was kind of still complaining. Again, it's very difficult to know with our children what the cause of the pain is. And we thought it might be reflux or silent reflux or something. She was just not vomiting anymore. And with the dietitians, they tend to mention about keeping a diary of foods that you give. And I think that's very tricky to do, because a lot of foods, it's not like you give it and it's going to get digested or show its reaction straight away, or even like a couple of hours. I think you're probably looking at 24 hours before you give a food and you notice its reaction on the body. And I think if you're giving something like chicken or meat, that could even be a longer process. So that was difficult for us to do. And I came across this intolerance testing on the web. Now, I don't know how effective it is, but it was really helpful for us, because we ordered a kit online, and we gave a blood test on the finger prick, sent it off, and it came back saying that Tara is 100% reactive to cow's milk. And that really shocked us, because we never thought Tara was allergic to that. And it kind of made sense, because she's on blended diet. A lot of her feeds get watered down with Jersey milk or whole fat milk, and we thought, okay, maybe that might be a problem. Also, eggs was one of the high reactive, not 100%, but this, I think, was about 50% or something. Eggs could have a problem with that, and wheat, and a number of other things. So we thought, let's just tackle the top three. So we took out, for the past few months, since March, we've taken out cow's milk, taken out eggs, and it's had a huge improvement on her well-being. And even her regular consultant was quite surprised, because they just hadn't considered that something so simple could have the answers to this problem. Again, it might not work for everybody, but I think it's definitely something that should have been provided by the NHS or by the consultants as an option. Hey, mom, would you like to get this done? But no one ever mentioned it. And as parents, I feel like we are so left to our own devices to do our own research on the internet for these little bits of clues and stuff. I mean, Facebook has been really, really good for parents to share these ideas. And whenever a reflux question does come up, I'm always popping this thing about, try alternative things, because they're going to have side effects.
Sorry.
Sorry, I just wanted to say that, give it a try. And obviously, certain children will need medication. I'm not saying you can eliminate it. We can't. We haven't been able to eliminate Gaviscon. That's definitely needed for Tara, and I wouldn't want to cause her discomfort if there is a medication that can give her even that little bit of a relief without a significant amount of side effects. We should definitely give them the medication, but also look at other avenues.
Yeah. I'm glad you made that point, because I think that people, well, doctors a lot of the time will jump straight to the medication, and it's particularly for people with Rett syndrome, whereas if it was a different child that's typically healthy, they might suggest other things first. Excuse me. And I'm not saying, obviously, like you've said, Minity, already, there are some people for whom only the surgery or only medication or only surgery, medication, and everything, like a combination approach, is going to help. But there's no reason that you can't look at some of these other things as well, such as food intolerances, which are obviously very personal. So the dairy, dropping dairy won't work for everyone, but dairy is something that a lot of people are intolerant to.
Shona's dairy free.
It's meant for baby cows at the end of the day, and they have 4 stomachs, you know. So just bringing that up, that's my aside. Have you, Debbie, tried other sort of dietary things with Shona?
So we're just like really at the moment the gastroenterologist, and she's so nice. She's such a lovely girl, and she's saying she's fighting for blended diet. They have a blended diet clinic, and this is where we're going now, really, is with the blended diet. And
so you have a dietitian that has a blended diet clinic?
The fight as a dietitian, who's because it's new to their doctrine, so they're not sure about it, like, and it's a lot of work, you know. It's like, I don't care how much work it is, if it works it's going to be good. So so we're pushing this just now, and it's making out as if it's like the dietitian making out as if it's a real challenge, and you know, it's a process, and you know, and I get the idea that the school's going to be like, oh, what do we have to do, and you know, so this looks like the next fight at the moment, but we'll push it, we'll get there, and we'll get it started. And I think the intolerance testing is fantastic. It's brilliant. I know you shouldn't have to go online and pay for something to do, but sure, it is dairy free, gluten free, and this makes a huge difference to her. And silly things like, we found out strawberries and apples, very, very struggles a lot with them. So anything that was based on anything like that was causing her problems. So I would say the intolerance testing is a brilliant thing. The only thing that they'll do NHS is for like an actual not intolerance, but like an allergy, and nothing came back on an allergy, but an intolerance came back really high. So there's a complete difference, and I don't know if doctors really see that. If an allergy is an allergy, if they don't have an allergy to it, then it's not a thing. I think we're more intolerances going down the routes of more of the herbal and more of the things like that, and doctors are not.
I don't think intolerance testing is like covered by NHS.
No. But I would say it's one of the definite things to do if you can afford to do it, you know.
I would also concur with the dairy side. When Lauren had her spinal surgery, we had a lot of gastro issues after that, reflux included. And she was moved on to a peptide-based formula rather than a whole milk formula. And it did make a difference, actually. So we limit the amount of milk that she has. And I think that probably has contributed a lot to her reflux. And certainly with the vomiting.
One thing that the NHS will do is through, even for people that have like IBS type symptoms, which one of my children does, not Amber, is that low FODMAP diet, where they do like an exclusion diet, where they take out one thing, everything basically, and then put things back very slowly. But you have to work quite hard to get that level of help, and especially in Rett syndrome, I think that would be really difficult. Christine, I see you a lot on blended diet stuff. So I think that you're quite heavily involved in blended diet, aren't you? So why don't you tell us a bit about your experience with blended diet? Yeah. When did you first go to that for Neve?
So Neve's 13 now. It feels like we've been doing it for ages. I think we were one of the first people in our county to do blended diet, and of course that was met with a huge challenge. I was threatened with a safeguarding by the dietitian. You know, she said, you cannot feed your child this, and I said, well, I'm not getting any help. You know, I'm more than willing to help. You know, for you to, you know, I'm more than willing to engage with you if you want to help me. But they were like, at that point, they were like, no, we cannot advocate that. So we were left on our own, and it was a really challenging time, because, as I say, we were threatened with safeguarding, but it was kind of like, well, what do we do? Do we just go ahead, or do we kind of do we stop this and just let Neve deteriorate? And as a parent, I just thought, yeah, I can't do this. So I just kind of thought, all right, okay, I'll run the risk and see what they do. And they kind of pretty much left me alone. And we were literally left on our own. So what I ended up doing was just tons and tons of research. I downloaded a calorie app. I mean, it was as simple as kind of downloading a calorie app and just basically working out what our calories had been prescribed on the NHS, and then kind of trying to mirror that in terms of foods. We quite quickly realised that there's lots of foods she didn't tolerate in terms of heavy, kind of creamy, high calorie foods, all the kind of foods that I wanted to give her to try and get our weight up, but we couldn't. So we went through it as a process of elimination, really, lots of trial and error. And as I say, calorie counting. And then we quite quickly invested in a high-powered blender. We kind of felt as though we faffed on with like little cheap blenders for kind of a few weeks, and they just burnt out quite quickly, and messed about with sieves. And I was like, oh, this is just crackers. So we ended up buying, like, I think it was a Vitamix, and that was the best thing that we ever bought. It's expensive, absolutely expensive, and you know, blended diet now is a routine. You know, we kind of we bulk buy and we bulk make our meals, we freeze them, so it's just part of our routine now. But yeah, that's kind of our story in a nutshell with regards to the blended diet. I think probably because I'd done it, there was other parents who were kind of encouraged to try it, you know, and then I think it quickly kind of spread. And then the professionals were like, okay, well, parents are doing it anyway, so we either support them, and, you know, so that's what they did. They kind of started to come on board. So the local hospital that Neve goes to is the RVI in Newcastle, which is quite a well-known hospital, and they do accept blended diet there. I think they are coming on board with it. I still get challenges, you know. There's still, when we go into hospital, there seems to be this kind of attitude as well, if you're going to do blended diet, you've got to bring your own meals in, you've got to do it yourself. It's like, absolutely fine, you know, I don't mind doing that. We leave on quite a kind of a limited diet anyway, so I don't mind doing our meals and preparing them and giving our meals. You know, I've always done that, you know, that's not an issue. But yeah, so that's kind of how blended diets start with us, and we continue to give blended diet to this day.
And that's really positive to hear. But as everybody else doing blended diet, Motility, what about you? Have you come up with the same problems with professionals, or are they on board in your area?
I think well, the first dietitian that Tara had, she kind of sat on the fence. She didn't say, oh, no, I'm not going to let you, Mum, but she was like, oh, I can't advise school to do it because it's not what we've been trained to do professionally. So I'm not going to say anything. And so the school's, or her teacher's approach at the time was, well, if dietitian's not advocating it, I'm not going to give it. And then when I pushed a bit more, the teacher said, oh, let me have a think about it. You know, I'll get back to you. And that conversation just carried on for like until the end of the academic year. I was like, okay, I'm not getting anywhere with her. And then luckily the next year Tara had a different teacher and a different dietitian.
Did you, sorry, just to stop you for a second. In the school day, what happened? Did she eat, or did she, what did she eat?
So she was orally fed, but she would eat so little, very, very little. I'd know that when she comes home, I'd have to pump her up with food myself.
But you didn't have to go in and give her?
No, I've heard of horror stories. Well, I'll say horror stories, like, you know, parents having to go in at lunchtime to feed their child. No. So so Tara wasn't given blended diet for that particular year. But then the next year, the teacher, they were like, the dietitian changed as well. And that had a huge impact. She was like, Mum, there's no harm in trying it. We're just going to get a risk assessment done. So she was checking, am I following the food hygiene things? and you know, if something were to go wrong, what's the backup plan, that kind of thing. And I think the dietitian was quite focused on calories, and as Christine mentioned, it is tricky because it's not as simple as, oh yeah, now let's load them up with full fat milk and, you know, cream and all that stuff. And I think that can also cause reflux when you go down that route of trying to kind of do that. And with us, we kind of like, no, I guess just even giving food that we as parents eat at home, even though it might not be as calorific, at least it's food going down her system. And I think that's the starting point to do, just because Tara's weight was very, very low. So if I can just even get it up a little bit, to me, that is progress. And then once I get to that, then I can think about introducing more fatty stuff. But it was a balance to achieve, because I've got the dietitian at one end saying, no, we need to focus on calories. And me as a mum, I need to focus on making sure that her reflux doesn't get aggravated with all this rich food.
Yeah. That's the thing, isn't it? And it's the same for every issue that we have. You're thinking about the complete picture and the overall well-being of the person, and they're thinking about their particular area and ticking their boxes.
Yes.
Helen, you were nodding away there. So are you doing blended diet as well?
Yeah, I mean, so Lauren had her spinal surgery in May 2018. And then in October 2018, she had her gastrostomy changed to a button so that we could start blended diet. We're actually really lucky in this area in that the dietitian and the team work closely with the gastroenterologist, who for us is based, our actual local hospital, albeit an hour and a half away, is John Radcliffe in Oxford. And the gastroenterology team there are really supportive of blended diet. And so locally to us, the dietitian team are also really supportive. So it was actually them pushing me towards doing it. And because Lauren was still eating orally, though not always reliably, we are still to this day doing a combination of oral and blended. The milk feeds, once we started sort of in earnest with the blended diet, we were able to drop some of her milk feeds, which actually was really beneficial because especially in school also are very supportive of doing blended diets. So literally in the last month, that started as well. So she's now having her breakfast and lunch are always blended. And then she has an oral dinner with us at home when we've got more time to feed her. And the impact on her school day has been significant because we've been able to reduce those milk feeds down that they would have to give us so slowly and over such a long period of time, both mid-morning and mid-afternoon, in order that it didn't cause reflux. But now that she's having a reliable meal, blended meal at lunchtime, we've been able to cut those 2 milk feeds out completely. And it's just opened up her school day. So she's, you know, they were pretty much within every half an hour, they were giving her something through her tube, whether it be milk, medication, water flushes, drink, anything. And now we've been able to condense that down into, you know, something that is worthwhile. And for the first time ever, she's putting on weight. You know, the last 6 months, every month, she's been weighed and she's put on, even if it's just little bits, it's all going in the right direction, and she's maintaining it. So, and from a reflux perspective, it's just helped a lot. And what it's also done then is also built up her hunger. She's been able, because we're not constantly giving her these milk feeds, she actually has a chance to get hungry. And so when we come to give her her oral meal at home, she's eating all of it because she's got an appetite. So it's worked really well for us, but we are, and I appreciate, because I know there are other areas of the country, like Christine was saying, where dietitians can be so against it, or, you know, the gastro teams, and that's a real fight. I can't imagine how that was actually You know, that's a real tick for you, Christine, to go with your gut instinct on that, because it would be a real fight, but we're just so lucky that they're so supportive. So they've even just put a risk assessment in at her respite centre, so they are now set up to do blended diet with her as well when she's there, which is great.
That's great.
Yeah, really great. And there is a really good on Facebook, there's a really good it's not Rett specific, it's just a general blended diet forum. I can't remember the name of it, but there's some really good hints and tips on there from parents, and if anyone is thinking about going that route, it's certainly a good group to join, because any questions you've got.
Diet UK?
Blended diet.
Yeah,
UK,
I think
yeah.
it is something like that. And I think there may even be dietitians on there as well, but certainly parents that are doing blended diet, and it's a really good informative group that if you've got any question, somebody will have the answer for it. So it's well worth joining that if blended diet is something you're considering.
Yeah, I agree. And also people can help you with all the practical elements of it, because it sounds very overwhelming at first, but actually, I mean, I suppose what I've kind of listening to everybody speaking about this has reinforced to me why we're doing these sessions at Reverse Rett, because there's such a wealth of experience and skill that people have had to build up, but also just an understanding of the fact that it isn't a one-size-fits-all answer for reflux. It's very much a combination approach and individualized to the particular person, but fundamentally it's you as parents that seem to get to the bottom of what it is that's going to work for your particular individual. One thing I would like to suggest is that we do have a follow-up session on blended diet with you guys from beginning to end, like all about blended diet and what. And Debbie, perhaps you'll come back as well and tell us about your experiences.
Hopefully, like, we should be getting this started. They're just making a big rigmarole at the moment, like, oh, it takes such a long time and we have to do that. But I just keep pushing and pushing. And if not, I'll just start my set. Well, they don't advise you to do that, but we'll need to get the ball rolling somehow. Well, but I do feel that they would come down the likes of what Christine said, like, you know, with the whole oh, you can't be doing this because we've stipulated that this is the calories and this is how she gets it, and they don't want you going off on your own and doing anything. It's very much controlled by them.
Well,
so
what have you said? You know, that the doctors had said, well, you can't be feeding this to your child, and my answer to that is, what do you mean you can't feed them food? Because that's what it is.
It does seem ridiculous. I couldn't believe how it was met. Like, oh, okay.
There has been lots of changes though, actually. So the BDA, the British Dietetic Association, they've changed their rules and regulations over the last few years to kind of accommodate blended diet, because they realise that parents are doing it. So they have got these risk assessments, which it does sound a bit like kind of defensive practice, but you know, if that's what we've got to do it, that's fine. Which I just wanted to quickly mention, I was invited to our local hospital to do a presentation on blended diet, interestingly enough. So that was quite funny, isn't it, how the tables turned? So 5 years ago I was threatened with a safeguard, and now the local hospital who threatened me with a safeguard and asked me to come and do a presentation on blended diet. And I did actually make that point during the presentation. I wasn't going to, but I thought, no, actually, people need to know. So I've actually done a PowerPoint, Rachel, on blended diet, which I'm happy to present if you want me to. It's it's really practical. It's literally starting from basics, but it's a dead practical kind of quick, you know, probably about 20-minute overview. But yeah, so more than welcome to kind of to help out with that. I am really passionate about blended diet because it's really helped us.
Yeah, no, that would be absolutely fantastic. And I think the main thing about it is, and we get this question all the time from, say, on ethics committees, when we're talking about people with Rett syndrome going to clinical trials, the people will always say to us, you know, it's a lot of a burden on the family. It gives them more to do. It gives them more hassle and this and that. And I suppose the overwhelming point is, when it's your child that's in pain, there's nothing that you wouldn't do to try and better understand it or to ameliorate the pain if you can. And this is just another one of those things that people have to get their head around and do get their head around, and it becomes part of what your everyday is. So we've slightly deviated from the original talk, which was about reflux, but I think this has been a very helpful discussion that's shown how blended diet can be part of helping with the reflux too. We are over time, and so I'm going to wrap up, but I just feel that it's been so helpful, and I'm really grateful to you, Christine, Motility, Debbie and Helen, for sharing your experience with us. And the next bite-sized session, and it's the last one until September, is going to be on chest infections with another expert parent panel. And actually we're holding that session in collaboration with Rett UK, and we have Yvonne Milne, who is the founder of Rett UK, as part of that panel. She is very experienced in chest infections, and I think that's going to be really helpful. And then we also have a family forum on the 9th of June at the new time of midday to try and get different people engaged. So the evening ones have been going very well, and they're quite nice. I find them quite relaxing, but it's just trying to see if different times of day work for different people. So Beth will send out, when she's returned from the hospital, or when she's able to, the details of those next sessions for anyone listening. And once again, just thank you to each of you for speaking to us today, and thank you to anyone who, everyone who's listening now and anyone who watches later on. And see you again next time.
Thank you.
Thank
Bye.
you very much.
Thank you. Thanks very much.